Hello, everyone. Thank you for joining us today. I'm Tanya Nash, a public health consultant and project manager at Allergy and Asthma Network. Welcome to the Black People Like Me virtual conference series, which addresses ongoing disparities and barriers to care for the Black community living with asthma, allergies, and related conditions. We have a few housekeeping items before we start today's program. First, all participants will be on mute for the webinar. We will record today's presentation and post it on our website within a few days. This presentation will be 1 hour long, and that includes time for questions. We will take those questions at the end of the webinar, but you can put your questions in the Q&A at any time. The Q&A box is located at the bottom of your screen. We have someone monitoring the chat if you have questions or need help. We will get to as many questions as we can before we conclude today's webinar. We will not be offering continuing education credits for this webinar, but we do have a certificate of attendance if you need it for your records. A few days after this webinar, you will receive an email with supplemental information and a link to download the certificate of attendance. Let's get started. Today's presentation is called Eczema Care in the Black Community, Empowerment Through Shared Decision-Making. This webinar may include sensitive topics that may be upsetting or triggering for some individuals. Topics related to mental health, such as depression and suicide, may be discussed by our presenters. Viewer discretion is advised. First, we will have Greg Clark Jr. share about his experience living with eczema, how to overcome feeling unheard about your diagnosis, and the importance of acknowledging the mental health aspects relating to living with eczema. Then we will have Dr. Alexis share how underdiagnosis and misdiagnosis of eczema uniquely affects individuals in the Black community. She will wrap up by highlighting the importance of shared decision-making and practical tips to help you have a better relationship with your doctor. Finally, we'll answer some questions from the audience. Special thanks to Insight, which has provided funding support to make this presentation possible today. It's my pleasure to introduce our first speaker, Greg Clark Jr. Greg Clark Jr. is a mental health clinician and patient advocate in Los Angeles, specializing in culturally sensitive, trauma-informed care. He empowers communities of color to overcome generational barriers and thrive. Greg's approach blends positive psychology and evidence-based methods to foster resilience and meaningful change. Thank you so much for being here today, Greg. I'll turn it over to you.
Hello, excuse me. Hello, and thank you, Tonya, for the intro. My name is Greg Clark Jr., and I'm from Los Angeles, California. I am here as a patient to share my experience story when it comes to dealing with severe eczema. At the age of 2 years old, believe it or not, at the age of 2, I was diagnosed with eczema. Unbeknownst to my family, my mom received a year's supply of topical steroids. And we were not as well informed as we should have been on the usage of the topical steroid treatment, but I saw amazing results. As a child dealing with scratching and constant fussing, the topical treatment really helped myself. It was so good for me that my mom started to use it on her moderate eczema as well as my sister. Eczema ran through the family. We, once again, had no idea any of the health awareness that comes along with using topical steroids long term. So usage for me looked like daily use. The topical steroid ointment became my primary skincare treatment. So after the shower, as I've gotten older, I'm putting this topical steroid on my skin, on my face, near my eyes, all of these different things, just once again, ignorant to the possibilities of what could happen. I do remember there was a time, senior year of high school, where I almost did not graduate high school. My eczema got so severe that I missed so much school that my school did not want me to graduate. My mom had to go through the Los Angeles Unified School District to appeal the school's decision. And fortunate for me, somebody on the board had a daughter who was going through a similar experience. And there was sympathy there for me to graduate. So during my senior year of high school, I didn't know what was going on with my body. I was an athlete. I played football. So having the shoulder pads and the helmet, being in the dirt and the grass, constantly sweating, I just saw my body, my eczema get out of control. Being a teenager dealing with eczema was very self-conscious for me, to the point where my friends didn't really make fun of me because they knew how severe my eczema was, but I can see in their eyes the pain that they had for me and what I was going through. My skin would constantly weep. If it wasn't red, it was probably purple. And me being self-conscious of how I looked, I constantly hid my skin under baggy clothes, which really didn't help as well. As I gotten older, I had gone through college, university. Once again, as a scholarship athlete, I played football and still dealt with severe eczema. Throughout my years, the topical steroid had been there as a comfort blanket, so to say. And as you can see in these pictures, it wasn't until I was 33 years old, I went on a family vacation to the Dominican Republic, and I forgot my topical steroid medication at home. Oh no. But this was the first time in my life, close to 3 decades now, that I'd been using this medication and I had been this long without it. Being in the Dominican Republic, I didn't know what was going on. If I probably ate something and I didn't digest it properly, having an allergic reaction, I had no idea that topical steroid use long term could impact my skin slash eczema to this point. And so this right here, where you guys are looking at, this was the biggest eczema flare of my life. Um, it was a very challenging and emotional time for me, because one thing that I discovered is, obviously we go to the doctor for care and support and to get better. But when your doctors start to look at you with the big bug eyes, like they don't know what's going on, that became a concern for me. That was the first time in my life when I realized that I should be more concerned about my health and my skin than the doctors could. Because if they don't have an answer, who am I left to go with? So during this time of my life, I was having severe allergic reactions. I was allergic to pretty much everything. I was able to eat grapes and watermelon. It was during the summer, thank God. And those were the two things that I ate for about 6 weeks where my body was not having any type of allergic reactions. After coming home from the Dominican Republic, I lost about 45 pounds in 4 weeks. So just seeing how my body would shift and change and not knowing what's going on with myself, let alone I'm going to support from doctors, working with my primary care physician, infectious disease doctor, and also a dermatologist. And we were all still up in the air. It was very unfortunate. So working with these three main doctors, there was a lot of skin tests, blood work to really come up with the diagnosis while I was still suffering. That was another challenge from my experiences, constantly going back and forth to different doctor's appointments, wanting to get better, but the idea of not knowing what was going on with my body. Obviously, during that time of my life, I was not working. My job, the job that I had at the time, they told me, take as much time that you need off to deal with your health and get better. When you get better, come back. 12 weeks after being away on medical leave, the employer thought it would be best if they terminated my employment. And so the health insurance that I had that was allowing me to see these doctors and have these tests done was pretty much taken from me. During the biggest flare of my life, as you guys saw from the pictures as well, I was also not just unemployed, I was evicted from my apartment. I saw my car get repossessed. And, thankfully for me, my mom had a converted garage in her house where I was able to stay, and that's where I moved. Otherwise, I probably would have been homeless. And this is interesting because these aren't things that you think about when we're dealing with eczema. One thing that I can share you from my personal story is dealing with severe eczema for me meant impacting my lifestyle and also making life changes to support or cope with the severe eczema along the way. Some of the things that really challenged me as a man of color, was really my mental health when I was going through this eczema flare. I was suffering severe depression. One of the symptoms at the time for me was anxiousness. So I was not able to sleep. You can also say insomnia. And I would constantly shake and have the chills throughout the day and night. The nervousness of not knowing what was going on in my life and what would happen led to suicide ideation, feeling as if I may be better just not being here, having to go through these challenges and this discomfort and calling this my life. It really impacted my self-esteem, my confidence, and also my future, not knowing what my future looked like moving forward. Some of the biggest challenges that I had in my experience with severe eczema was working with being a man of color. And the reason I say that is eczema for me shows up differently than it will in other people. And my doctors, or the doctors that I worked with at the time, did not have much experience dealing with people of color and eczema. So I saw a huge discrepancy there. Also, when working with the infectious disease doctor, guys, I'm a clinical therapist. I love research, finding out, answering questions, and getting to the result, finding solutions. So even though feeling depressed and having anxiety, I went to the doctor and I expressed this energy, like, how can I get better? I would come with some of the information that I found online. And his answer was, I'm the doctor. You should be listening to me. So I really felt defeated as a patient, as if there was no partnership with the doctors. I was just supposed to kind of take the orders that I was being told. So it really left me in my personal experience to ask myself, am I getting the best support with Western medicine, or are there other opportunities and options out there? For me, that's when I decided to put on my clinical thinking hat and really just navigate what's going on in my body. How is eczema showing up? What are my triggers? Understanding that there are foods out there that can increase my eczema flares. Also, which foods can help decrease. But one of the biggest things that I learned with my eczema journey was understanding my mental health and understanding that dealing with severe eczema the way that it was presented to me, I'm not going back to the person I was. We kind of heard that in the pandemic, going back to a new normal. I really gravitated towards the idea of understanding that I'm creating a new identity coming out of this. And so that new identity for me was really living a healthier lifestyle that promoted life without eczema, or being able to manage the flares a lot better. Thank you guys for taking the time to listen to my story, and I look forward to answering any questions at the end.
Thank you, Greg. We really appreciate you shining a light on the impacts of eczema. Next, I'd like to introduce you to Dr. Alexis. She is a clinical assistant professor of pediatrics at NYU Langone and Weill Cornell, and she has over 15 years of experience treating pediatric and adult patients in allergy and immunology in New York. Born in Germany, she trained at Morgan Stanley Children's Hospital and North Shore, Long Island Jewish Medical Center. Dr. Alexis is a fellow of multiple professional societies, including the Quad AI, ACAAI, and the American Academy of Pediatrics. Thank you for being here today, Dr. Alexis.
Thank you, Tanya, for your kind introduction. And thank you to Greg for sharing your story with us. And welcome to the presentation, Eczema Care in the Black Community, Empowerment Through Shared Decision-Making. Next slide, please. These are my disclosures. Next slide, please. So welcome. So for the next 30 minutes or so, I'd like to talk about atopic dermatitis in general, and then focus on causes, symptoms, and presentations, especially in atopic dermatitis in patients with skin of color. Then we'll talk about the visit, how to prepare, what to expect, and the value of shared decision-making. And then we'll talk about therapeutic options. We have great evidence-based guidelines, and there have been a lot of advances in medicine. So we'll talk about that as well. Next slide, please. Let's start with talking about atopic dermatitis. Next slide, please. All right, so Atopic dermatitis is the most common chronic inflammatory skin disease. Patients present with really dry, itchy, and inflamed discolored or red skin. But it's really the itch that drives the patient the most. The itch can be overwhelming and really overshadow all of the other symptoms. Atopic dermatitis is a specific disease. It's a chronic disease. What does that mean? It may wax and wane over time, and it may last months, if not even years. It's not contagious, and it may affect you at any age. It's often considered a childhood disease, but you can develop it in adolescence and even as an adult. It may be the first step of the so-called atopic march, where you develop eczema first or atopic dermatitis, and then food allergy, asthma, and/or allergic rhinitis, which is hay fever. So if you think about eczema and the atopic dermatitis and the itch and the constant itch, it may affect not just the skin, but it may affect the way you see yourself. It may affect the way others see you. It may affect your social interactions. It may affect your sleep and your quality of life. And it may affect your mental health, as in depression or anxiety. Next slide, please. So how common is this? It's actually quite common. About 16.5 million Americans have a history of atopic dermatitis. The prevalence is 10 to 15% in children and 7 to 10% in adults. Again, it may affect you at any age. It turns out we think of eczema as a childhood disease. About 60% first present during the first year of life. But again, you can develop it in early childhood, adolescence, and even as an adult. The severity can range from mild, moderate to severe. And in terms of distribution of lesions, that often changes by age, meaning when you're a baby, it often appears on your cheeks, but then it can travel to your neck, your chest, the large folds, across from the elbow or across from the knee, the hands, the feet, the ankles, the wrists. It can affect all over your body. It can affect all over your body. Let's see. So again, in children, it can be about 13%, and in adults, it can be about 7%. All right, there's a poll question. Are we waiting for the poll to be done before I go on? Or should we give it another minute?
And the poll is finished.
And the poll is finished. Okay, let me just go. Thank you. All right, so when I put the slides together, well, let me just, this window popped up 1 second. Great. When I put the slides together, I used Google Images, and I put in eczema because we know that's what our patients do, right? Maybe this is eczema, let me Google myself. So as you can see, we can see multiple presentations. It's quite a diverse a disease where we can have a clinical diversity. So what do we see? We see pink, we see red, we see hands, we see a neck, maybe that looks like a trunk. But there's something that we may also see, and that's limited examples of eczema and skin of color. So if I'm trying to figure out, use Dr. Google to figure out what I have, turns out I'm actually not seeing myself, which might be an issue. Next slide. Next slide, please. Oh yeah, there we go. So, sorry, go back one, please. Yes, so I did the same. I used Google Images search to kind of see, hold on. I did the Google Images search to see what eczema looks like in skin of color. I put in eczema in skin of color, and this is what I see. So this looks a little bit different, right? We don't see that pink or that red color anymore. We see other colors. We see red as well, but darker red maybe. We see brown, we see purple, we see gray. So it just looks a little bit different. We also see different areas of the body that may be affected, and the rash looks a little bit different, right? So eczema and skin of color can present very differently. It has very diverse clinical presentations. So if you're not familiar with these presentations, you might either misdiagnose or underdiagnose these diseases, and that may lead to undertreatment. Next slide, please. Okay, so let's look at a few numbers. How common is this? Let's look at statistics. So Black patients in the United States experience atopic dermatitis with greater prevalence, greater severity, and greater persistence. There's a study that shows that you have a 1.5 times higher likelihood of developing atopic dermatitis when you're Black as compared to being white. There's also, just gonna reduce the pop-up window. There's also greater utilization of, oopsie, sorry. I keep seeing the pop-up window. There's also greater utilization of going to the emergency department among Black and Hispanic children when compared to white children. And Black children and Hispanic children are more likely to have missed at least 6 days of school because of atopic dermatitis when compared to white children. All right. Next slide, please. Thank you. So there is also data that shows that Black children with poor atopic dermatitis control are not being seen by a specialist. So there's underutilization of being seen by a dermatologist. There's data that shows higher out-of-pocket expenses for Black patients. And there's a big study out of Johns Hopkins that looked at 18,000 adult patients with atopic dermatitis. And these patients were less likely to receive different atopic dermatitis therapies, such as dupilumab, which is an injectable medication, as well as crisaborole, pimecrolimus, tacrolimus, and desonide. These are all topical therapies. And the Black patients were all less likely to receive those. Next slide, please. Thank you. So what about the burden of disease that goes beyond the skin, right? So this is data from a web-based survey of about 700 patients, and they were asked about the psychosocial burden of the disease. And 42% said that they were bullied because of their skin condition. Another 42% said it made them feel depressed. And 75% received negative comments from persons close to them about their skin condition. So this really shows about the impact of quality of life that goes beyond the skin. Next slide, please. Thank you. So how do we diagnose atopic dermatitis? The diagnosis is a clinical one, meaning, the diagnosis is made based on the patient history and the clinical presentation. So the clinical presentation will lead to the right diagnosis, which then lead to the right therapeutic interventions. However, if you don't recognize the clinical presentation, you are not going to get to the right diagnosis. And therefore, you will either just undertreat or not treat correctly what you see in front of you. And then just every once in a while, if it's really tricky and it's really not clear what that rash actually is, we may do a biopsy where we take a small amount of the skin and then send it to pathology, send it to the lab. That's often done by the dermatologist and less often by an allergist. Next slide, please. All right, so how do our patients present? What are the clinical characteristics? There are nuances in the clinical presentation. There's altered appearance of erythema, which is the redness, which we'll talk about a little bit more. There are variations in anatomical distribution. We often, in patients of color, have truncal involvement, meaning your trunk is involved, not just your arms. There are unique presentations. We call them follicular, psoriasiform, and lichenoid, and we'll talk about that a little bit more. And dyspigmentation or discoloration is more common. We can see hypopigmentation where the skin turns lighter after injury, or hyperpigmentation where the skin turns darker after injury. Let's take a look at some pictures. Next slide, please. Great. So on the left side, we see two different arms, and they both present with acute atopic dermatitis. But what do we see? So erythema is a reddening of the skin due to injury, inflammation, or irritation. So if you think of erythema, classically we think of bright red, but if you take red and you add pigment to it, now you can see violet, purple, brown, or gray. So if you're looking for that fire engine red, you will miss the diagnosis. So the underestimation of erythema or inflammation may lead to undertreatment. So both of these arms presented with acute, or both of these patients presented with acute atopic dermatitis, and both of these rashes cleared within 2 weeks of therapy. Next slide, please. Great. So here we see 3 presentations that are often seen in patients of color. On the left side, we see follicular prominence. Follicular prominence may be the only sign of atopic dermatitis, especially in pediatric patients with skin of color. So as you can see, it almost has like a little bit of a sandpaper-like appearance. It's often on the trunk. It doesn't look very impressive at all, but it's really, really itchy and sometimes a little bit tricky to treat. In the middle, we see lichenification. This is skin thickening and exaggerated skin markings secondary to constant scratching. So this is really a reflection of the burden of disease. This child is scratching so much that we see lichenification. And then on the right side, we see dyspigmentation, where the skin, there's like a little halo around the darker patch. And so again, if you have highly pigmented skin, if there's inflammation, it either turns lighter, which is hypopigmentation, or it turns darker, which is hyperpigmentation. And depending on how long this is going on, it may take weeks and sometimes years to really have the dyspigmentation even out again. Next slide, please. All right, so we all want to understand why this is happening. So this is kind of a snapshot of the skin that talks about potential causes. There's a lot of stuff going on this slide, but let's walk through the slide. So we see a person scratching. We have in atopic dermatitis increased water loss. What does that mean? Really, really dry skin. And because of the constant scratching, there's an issue with the barrier, the skin barrier, which leads to the invasion of bacteria, of pollen, of allergens, pollutants as well. So what happens next is that there is an exaggerated response from our own immune system that happens. And that's what we see all the business on this slide. We also see different therapeutics on the slide that are either already FDA approved or that are still in research. So a potential cause is the dysfunction of the skin barrier and an imbalanced immune system. Next slide, please. So when we think about treatment, it's complex, right? When we think about treatment, we really want to address the dysfunction of the skin barrier, which means tons of moisturizer, and the imbalanced immune system, which means some kind of anti-inflammatory medication. And we want to avoid triggers if there are triggers, if we know about these triggers too. Next slide, please. All right, this is another way of thinking at potential causes. If you have a mother or a father who have any of these 4 disease states, and I share this slide with my patients all the time, which is the atopic march, it's atopic dermatitis, food allergy, allergic rhinitis, and asthma, you have a 70% chance of developing any of those 4, right? So family history. There's also a mutation in the so-called filaggrin gene that may predispose you to developing atopic dermatitis, although that is not that often seen in patients with skin of color. On the other side, there are social determinants of health. And social determinants of health can be environmental factors, socioeconomic factors, access to quality care, right? The definition of social determinants of health, as per the WHO, are the non-medical factors that influence health outcomes. These are the conditions in which people are born, grow, work, live, and age. So, we're learning more and more about potential causes, and it looks like it may even be more of the non-medical factors that may drive the disease state. Next slide, please. Thank you. So the American College of Allergy, Asthma, and Immunology, which is one of our parent organizations, kind of wanted to learn a little bit more about their patients with skin of color. So they sent out a questionnaire to their providers. And the providers answered back. They asked themselves, they asked their patients, what can we do? So 68% acknowledged that racial disparities hindered adequate treatment for atopic dermatitis and food allergy amongst individuals with skin of color. And then the providers asked their patients, what are your concerns? Concerns were access to care, access to, especially a specialist who takes Medicaid or any insurance, inadequate coverage, having no coverage at all, seeing a specialist with specific knowledge, and just where to find good resources and good information. There are concerns about the burden of the costs in just tests or therapies. There were concerns about policies and infrastructure that limit access to patient education. And there were also concerns about inadequate research involving patients with skin of color. Next slide, please. All right, let's think about going to the doctor, right? So you have this disease state and you're now ready to go to the doctor. And there are a few things you can do. So first of all, who you're going to see. So it might be an emergency room physician. It might be a primary care provider like your pediatrician. It might be a specialist like a dermatologist or the allergist. It might be online in telemedicine, or it might be in person. Again, it might be a community-based or a hospital-based clinic. So each of these providers, they have a fixed slate that they devote to seeing the patient. And that time can be either 10 minutes or 45 minutes. And what you want to do is you really want to maximize that time that you spend face-to-face with your provider. And there are a few things you can do that to make it a little bit more smoother, basically. So think about your history. When did the rash start? Is this a brand new rash? You've only had it for 3 weeks, or you've had this since you were 3 years of age. And in that case, what makes it better? What makes it worse? Have you seen other providers? Have you seen other treatments? So just jot down a few notes before you go in. Bring in all the creams you have tried. That white tube with a blue stripe, I can guess what it is, but if you have a picture, it just makes it so much easier. Take pictures of your creams. It's just, if you can't remember, which nobody expects you to, take pictures of your rashes. They change. And, depending on where you are, it may take some time for you to be seen. So that rash may change completely, or it might even be gone by the time you see the doctor. Think about your insurance before you go in. Do you have a copay? Do you have a co-insurance? Do you have a deductible? Do you need a referral? It's nothing is more heartbreaking than you go, to you taking that morning off, you're going to the specialist, and then you don't have a referral. And sometimes, the primary care can send it over, and sometimes they can't. So think about all these things before you go to the doctor's office. It'll just make things so much easier. And then for patients who have had this for a long time, sometimes they're well aware of their medical formulary. What is that? So each insurance has a few medications that they prefer, and that's different for each insurance. So even though there might be a few things that I think are great for you, your insurance may or may not cover that. So I have a few patients who are well aware of their medical formulary, and they're like, doc, this is on the formulary, that's on the formulary. Do you think that's going to work? So, things are really complex. And then what is your goal? So it's great to have a goal in mind. Obviously, keep your mind open, but it's good to have a goal in mind when you go in. Are you going in to get a diagnosis? Are you going in for a second opinion? Are you going in to hear about the latest and greatest, what's happening? It's good to have a goal in mind when you go to the doctor's office. All right, next slide, please. So from our standpoint, what's going to happen? We're going to ask you a lot of questions. I love to ask questions. It's almost like being a detective, right? When did this start? Where is this? What makes it better? What makes it worse? How long have you had this? We ask about your past medical history. Do you have history of asthma, allergies, food allergies, environmental allergies? We want to hear all about this. Family history. Then this is really the time to not be shy. You want to show to the doctor all the areas that are affected. Sometimes I see a person and their face is clear and their hands are clear, but the rest of their body is covered. So this is really the time to speak up. And then it's completely fine to ask your doctor questions. Hey, doc, what do you think is the diagnosis? Which therapy do you recommend? What are the pros? What are the cons? How long can I use these medications? And when do you think I should start seeing results? And what can I do in between flares to keep my skin nice and well? You can ask for resources. I talk a lot during the visits, and I don't expect anybody to remember everything I ever said. So I like to give handouts. I like to give a summary. You can ask for online resources. There's something called the Atopic Dermatitis Action Plan. Sometimes if you get multiple medications, it's good to know what goes on the face, what goes on the body, how often can I use these. So ask for something in writing if you can, or just jot down notes during the visit. There are sometimes objective measures that help us really understand the disease burden. Again, if my skin isn't bright red, you may think I'm not that inflamed. But if I ask about itch, hey, on a scale of 1 to 10, how bad is the itch? And you'd say, it's a 9. That kind of tells me this is really acute. We ask about sleep. How often does this keep you up at night? We ask about missing school. We ask about missing work. So all of these are objective measures that we can follow that gives us a better sense of the severity of the disease. And there are other objective measures like the atopic dermatitis control tool. We'll talk about that a little bit more. Next slide, please. All right, so there are tons of objective measures to kind of follow the disease state. Some of them are just used in clinical trials like the EASI score. The EASI score, it takes a little of time to kind of see what the signs and symptoms are, but these are usually used in research protocols. We can follow the symptoms with the POEM, which is the patient-oriented eczema measure. We can see that on the right side. And it's basically 7 questions that look back at the last 7 days, and they ask about being itchy, or about sleep, or about bleeding, or about weeping or oozing of the skin, cracked skin, flaking skin, feeling dry or rough. So those are the things we can measure every time we can. It doesn't have to be a formal questionnaire. We can also just ask these questions, but it's kind of good to get a feel of how the disease affects your skin. There are also quality of life measures. Again, they're often done in the research setting for adults, children, and infants. And something called the eczema control test, or the atopic dermatitis control tool that also kind of follows how your eczema is controlled. And if you come up with a number, let's say it's 28 this time because your eczema is really not well controlled, so the next time I see you and it's a 15, it tells us that we're making progress. All right, next slide, please. All right, I love this slide, and here's the reason. So it turns out we now have a ton of great options how to treat you. So we have guidelines, it turns out, and these guidelines are published every few years, and we just got new guidelines last year. So who's this on the table to come up with these guidelines? It's patients, caregivers, it's specialists, which is the dermatologists and the allergists, it's primary care providers, and it's allied health providers too, pharmacists, nurses. So it's really everybody comes to the table and they look at the literature and they discuss what works best for patients. And then so these interventions are depending on how severe your eczema is, whether it's mild, moderate, or severe. And as you can see, we have 2 pages full of interventions. So we have topical creams, as in steroids. There is a place for steroids that can be used very safely, but you can't use them like a moisturizer every single day. There are non-steroidal topicals. We have actually quite a lot of them. So, and then there are bleach baths. Then there is elimination diets, which we often don't recommend for different reasons. You can go on allergy immunotherapy, which is allergy shots for your eczema. And we have systemic treatments. We have pills, we have injections. We can give you an injection every 2 weeks. We can give you an injection every 4 weeks. So there really now are options that we can offer you that we didn't have before. And these are evidence-based guidelines. So, if you haven't seen a physician in a while, please come back and have a conversation with your doctor. All right, so next slide, please. So when they wrote these guidelines, they also commented on patients with skin of color. They said there are clinical considerations and health disparities. So there are suggestions for conditions to consider when applying the guidance on an individual patient base and also a population societal level. So they talk about different morphologies. We talked about that a little bit. They talk about erythema as transient skin alteration, characteristic of active AD inflammation. I think that's spot on. They also talked about post-inflammatory dyspigmentation. Again, the skin turns either lighter or darker with inflammation. And then they commented that the principles of atopic dermatitis care remain similar for all skin types, which I think is really important to note. Next slide, please. Thank you. So this is data from the other Dr. Alexis. He wrote an algorithm for the management of atopic dermatitis in people with skin of color. So he really says to focus on the patient and the caregiver education. When I see patients, I often hear, I saw someone and they gave me a tube and the rash got better and then the rash came back. Yeah, that's because this is a chronic disease, right? This may hang out for months or even years. So it's kind of good to know these things. Minimize inflammation. It's really important to protect the skin barrier. Remember when I showed that busy slide, inflammation in the skin barrier. Those are the 2 things we want to focus on. Consider cultural practices, right? There are some families or some practices where we use a low fat to really, scrub our skin nice and clean. This is not the time to do that, right? If your skins are inflamed, this may not be the right thing to do, but, talk about that with a patient and you really want to prevent long-term dyspigmentation. That's really the goal. All right, next slide, please. All right, so what is shared decision-making? So it turns out shared decision-making was first mentioned in a publication 25 years ago, but it's really taken some time to kind of trickle down to all aspects of care. So shared decision-making is a practice in which a healthcare provider works with a patient or caregiver to incorporate their unique preferences and values into decisions about medically appropriate treatment options. Meaning, you take the expertise from the healthcare provider, they help with the diagnosis, with the treatment options, they talk about potential benefits and harms, and expectation of treatments, and then you take the expertise of the patient, their values, their lifestyle preferences, and that may depend on current cultural, social situation and previous related medical experience, and you merge them and you come up with a decision about the therapies together. And again, now we have medicated creams, which are steroidal creams, which are non-steroidal creams. There is a daily pill. There's several different daily pills, actually, injections every 2 weeks, injections every 4 weeks. There's medication that's indicated just for pediatrics. There's medications indicated just for adults. So all these things can be combined together. We make that decision together. Next slide, please. So how do patients feel about shared decision-making? So the National Eczema Association sent out an online survey a year or 2 back, and they questioned over 1,000 patients. They were older than 17, mostly female audience. And they kind of asked, so how do you feel about shared decision-making? So about 5% or so said, you know what? I prefer the doctor make all those decisions. I don't want any part of it. I'll do what the doctor says, 5%. About 10% of said, you know what? I know what I'm doing. I'm going to make that final decision. I got this. But the majority actually said I prefer to make the decision after seriously considering my doctor's opinion. So, those days where the doctor goes in and says, this is what we're going to do. No questions. Great. I'm out. Those days are over, right? It's patients are taking ownership. They want to make the decision for their own body. So again, patients preferred a larger role in decision-making for their care. Next slide, please. All right. So this is more data where the American College and the American Academy, a joint task force for practice parameters, those are the people who help write those guidelines. They looked at preferences that patients and caregivers have. They looked at over 7,000 studies. They included 62, which included almost 20,000 patients. And they found out that a strong patient-clinician relationship really improved treatment adherence. So this is not to be underutilized. So it's really important that you have a good relationship with your provider. It's often a long-term relationship. So it's important that it's a good relationship. Next slide, please. All right. So atopic dermatitis and skin of color approach to treatments. So the goal is really long-term control. You want to look for special personalized care, empathy, and patient-oriented communication. We talked about the importance and value of shared decision-making. And, if you work with your primary care and you get better, if it's mild disease, fantastic. If you don't, come see a specialist. There have been so many advances in medicine, even since the guidelines were published just last year. 4 more medications have been FDA approved for atopic dermatitis. So, if you haven't seen a doctor in a few years, there's definitely more we can offer you now that we didn't. And you're certainly not alone, right? Remember, 17 million people. Find your community. Next slide, please. All right, so these are excellent resources. The one on the top left is called the Skin of Color Society. It's a dermatology, a physician-driven website. They have fantastic resources, and you can see that little window, Find a Doctor. There are links to providers who have expertise in skin of color. On the right upper corner is the Eczema in Skin of Color website. It's done by the Allergy Society. Again, an amazing resource for patients. Then we have, of course, the Allergy and Asthma Network, amazing webinars, an amazing there's a great itch podcast. I would like to just throw out a shout out to my colleague, Dr. Payal Gupta. She hosts an amazing podcast, and you don't have to listen to all of it. You can just pick a few episodes, but so much valuable and good evidence-based information. And then there is the National Eczema Association. Again, amazing resources, all really patient-oriented. There's a lot of great stuff out there, not just on TikTok. These are, really good resources for patients. All right, next slide, please. All right, so this is the end of my presentation. I hope I threw out a few pearls. Atopic dermatitis in the Black community can be more severe, more persistent, more prevalent. We see variations in clinical features. It can be a chronic disease, right? You really want a long-term partnership with your provider. Early and sustained control are really keys to best outcome. I have a few patients who kind of keep waiting for the rash to go away. It often just doesn't, right? It's a chronic disease. It might be genetic. Just have that conversation. There are evidence-based guidelines, which are just really brand new. And again, I said 4 more medications have been FDA approved since then. And we all understand the value of shared decision-making. Thank you for your time today.
Thank you, Dr. Alexis. Now we're going to take some time to answer some questions from our audience. And we have some wonderful questions, and I'm going to try and get to as many as I can. I'm seeing some themes in some of the questions, and so we'll try to tackle some of those. We see a couple of questions about hyperpigmentation. And so the first question we'll do is, do you see a lot of cases with hyperpigmentation that persists beyond successful treatment of eczema? And in those cases, where the hyperpigmentation persists, what kind of treatments have been helpful for that?
Yeah. So my first thought is always, let's prevent the hyperpigmentation from happening in the first time. You can develop hypopigmentation when its skin turns lighter. due to inflammation, but also medication overuse. So if you use a very strong topical steroid for a long time, the skin can turn lighter. The hyperpigmentation, I don't see that with medication use. I just see that due to inflammation. So again, the key is to prevent it in the first place. If you can't do that, it can take time to heal. The skin will even out by itself over time if you address the inflammation. The other thing, often that arm I showed, right? Initially, when I showed the two arms back to back, initially when the patient came in, said, you know what, my arm's really, she didn't say hyperpigmentation, but really dark for a long time. And I said, you know what, this actually isn't hyperpigmentation. This is erythema. So we also want to differentiate between long-term post-inflammatory hyperpigmentation and acute erythema, because that arm cleared within 2 weeks. It was actually redness that wasn't recognized as redness. So keep that in mind as well. And then I do have a few patients, they scratch so much and so hard over time that the pigment got lost. So it's depigmented, and that can be persistent. So that we have to be a bit careful with. You can get really so itchy that you lose that pigment, that you destroy the melanocytes. Again, it speaks of the burden of the disease. So time will help. Sometimes seeing actually a dermatologist, they have a few tricks that they can do to help the hyperpigmentation move along, but only once the inflammation is gone. You really need to address the inflammation first. Once it's gone, the skin is smooth but darker. So not bubbly, not itchy, not scratchy. If it's smooth and darker, the dermatologists have a few tricks up their sleeve to treat the hyperpigmentation.
Thanks. Okay, so we have another question, and this question would be good for either Greg or Dr. Alexis. How can a school nurse best support a student with eczema that is dealing with some of the emotional aspects that go along with dealing with eczema?
Eric, do you want to jump in?
Yes, thank you, Dr. Alexis. What I would share to the school nurse is first being able to identify where that child is right now with their emotional state. Have they been triggered to a place where their mind is not stable and grounded, or are they still stable and grounded inside of them? And then secondly, offering support through sympathy and empathy, really being able to identify where the child is and giving examples, or maybe even being a little transparent with your personal story or something that may relate to what the child is experiencing. But then also, as before the child were to leave, I would recommend maybe allowing the child to journal or write about the experience or what they're feeling about the experience and things that they can do as far as coping mechanisms to overcome the burdensome of having eczema and dealing with other children that may not be as understanding.
I think that's fantastic. I would just like to add to that, educating their peers is helpful. They may not understand what they see. They may think it's contagious. They may think it's dangerous. Maybe having the mom coming, we even talk to the teacher if it's okay with the kid, obviously, to just educate their peers a little bit that this, nothing that the kid did or didn't do. It might be genetic. It's really itchy. It's not contagious. And they can support the kids.
All right. We have a few questions about bleach baths. Dr. Alexis, can you talk a little bit about that? One person asked, is it true that bathing in water with bleach is good? And then another person asked a question about it as well. So can you talk a little bit about that?
Sure. So, what I mentioned a little bit about the pathophysiology, how does eczema exist? Some of this talked about bacteria, right? Pathogens. So sometimes there's a bacteria called staphylococcus, where your skin is colonized with staphylococcus, and that drives the disease state even more. And we believe that bleach baths are helpful with that. There is a recipe online that tells you exactly how much bleach to put in your bath to kind of help kind of get rid of the staphylococcus on your body. So it's interesting, though, that in recent years, we've stepped away a little bit from bleach baths because some of the medication that we offer, the biologics, kind of just because the skin is healing, it actually also, the patients have less infections on their skin as well. So it is still a thing that we use, but less commonly so because we have a medication that addresses some of those disease states a little bit better now. Yeah.
Okay, this question was for Greg. Greg, do you find that certain surfaces, fabrics, or textures exacerbate your condition?
Yes, I would agree with that question. When it comes to the fabrics of clothes, even for me, in my experience, my skin was so severe. The idea of taking a shower or getting in water was horrendous. And it took maybe 2 or 3 years for me to mentally process what that was like back then as opposed to now. But most definitely, what we're putting on our skin as far as clothes, it could also serve as a trigger. It did for me in my experience, and it kind of led me to really find the best comfort that I could.
Yeah, wool and rough fabrics can often be a trigger, and so can fragrance sometimes, depending on the patient. So that's why we often, advocate for fragrance-free creams, lotions, detergents, to remove those triggers.
Okay, the next question, is Vaseline okay to use for immediate treatment if nothing else is available?
So two things, right? It's dry skin and inflamed skin. So for dry skin, Vaseline is fantastic. Petroleum jelly is fantastic, but it won't address the inflammation. Keep that in mind.
Next question, Dr. Alexis, does environmental exposure in childhood versus adulthood, how does that play a role in the severity of eczema?
Environmental exposure. It depends what you mean by environmental exposure. For example, if you grew up with a cat or a dog, you're fine while you grew up with a cat and a dog. You go away to college, there's no exposure for a while. You come back, now you're allergic. Now when you come back, it flares, exposure to cats and dogs flare your skin. So that's an issue. Oh, talking about environmental exposure, actually, let's talk about food a little bit, right? So there's a lot of data out there that if you eat a food and you tolerate that food every single day, especially in children, it's a bit tricky to stop that food. So let's say your kid has eczema, and we know eczema is a childhood disease. 60% present before the age of 1. Let's say you want to see whether milk is the trigger, and your kid is drinking milk every single day, it also has eczema. If you take that milk away, even though the kid is drinking it every single day, let's just say for a month, when you reintroduce it, you can develop a severe allergic reaction. So now you went from tolerating the food to being allergic to the food, and it didn't clear eczema. So we really are stepping away from food elimination diets for that reason. It happens more so in children, less so in adults, although it can happen in adults. But that conversation of taking away foods in terms of talking about exposure, you really have to be careful with. So much so that we now introduce foods early, right? No longer late. So this whole, thinking of introducing certain foods when a kid is 2 years of age, we don't do that anymore. As soon as your kid is 6 months and sits up and tracks you when you eat, and they're ready to eat those foods, we give them everything now, especially peanuts, especially eggs. Now, if you have severe eczema, your kid is at increased risk for especially eggs and peanuts. So I would see a specialist in that case. But beyond that, we really want to introduce all foods nice and early.
I would like to add, before we go on to the next question, environment. Environment, from my experience and also working from a mental health background, environment can be very broad nowadays, and we can niche it down. Dr. Alexis mentioned food. Something about my environment that did get noticed during my biggest flare was mold in the home behind the walls, and how that could hinder the environment for a healing environment. But then also, what is our mental environment like? What is our emotional environment like? Because for me, those did play major keys in my experience as well.
Thank you for bringing that up too. There's tons of data now. The whole discussion, genetic environment. It's a lot of environment, right? It's living next to a motorway where there's toxins in the air. All these things now we understand. Oh, wait a second, that actually seems to be playing a role as well. So yes.
We've had a couple of questions about wet wraps or using wet socks on areas after covering with Vaseline to moisten the skin. What are your thoughts about that, Dr. Alexis?
Yes, so it's interesting. When I see babies with atopic dermatitis, their diaper area is always clear. Why is that? Because the diaper area is always a tiny bit moist, and you almost want to replicate that, not the diaper area, but the moisture, right? So wet wraps is basically that you take a pajama, you wet it, you wring it out so it's just a tiny bit wet. You put on the medication first, you put on the wet pajama, and then you put a dry pajama on top so the kid isn't cold. And then you let them sit for a few hours and then put them in a dry pajama. So basically what you want to do is you really want to infuse the skin with extra moisture. So those are wet wraps. They work really nicely. They work really well. You can use them under the guidance of an allergist or a dermatologist.
Okay. We have another question about asthma and eczema. Do you find that many patients with asthma are diagnosed with eczema? And if so, can you give a correlation on why that may be?
Yeah. 4 disease states. I call them cousins. They're cousins. Atopic dermatitis, asthma, food allergy, and allergic rhinitis, which is hay fever. If mom or dad have any of those 4, you may have any of those 4. So that correlation just happened to be eczema and asthma, but you could have eczema and food allergy. You can have eczema and allergic rhinitis. Those 4 are cousins. The genetics is there. They often go together. Inflammation.
This question is for Greg. What physicians did you find to be most effective in treating you?
I would say my primary care physician was the most effective in my treatment. And I say that because I saw him the most, and it seemed to be for rapport, not rapport, but for emotional support. During the 90 days of when I was working with doctors, I didn't feel much support from them, to the point where there were 5 different times in those 90 days I went to the ER. And the ER would always send me back to my primary care physician because my vitals were within normal range. So I would say I built the best relationship, or felt the most supported with him. But once again, not because there was support, emotional support was there. Let me just clarify that. There was emotional support, yes.
Yeah, relationships matter, right? This is a chronic disease. It can be a chronic disease. You need to work with someone, or you want to work with someone who you can work with. Yeah.
There was a question about, is there a place where general practitioners or family physicians can get more experience in treating and recognizing eczema in patients with different skin tones? Or any place where they can get a training where a new doc can shadow them and get more expertise to take back to their practice. Dr. Alexis, do you have any recommendations or websites to share more information on that?
The Skin of Color Society, they host a yearly meeting where they educate any provider. But I think they're also, if you just Google, Skin of Color, there are webinars. I feel like at the allergy conference that I go to every year, there's a talk on skin of color. I feel at the American Academy of Pediatrics, there are webinars and CME resources where you can definitely learn more about skin of color.
And I think we have time for one more question. There was, some questions about the harmful effects of long-term steroids. And so one person asked, is there a non-steroidal cream that you would recommend for a child with severe eczema?
So, that busy slide I showed that I said is my favorite slide. Absolutely. It depends on the age of the child. And even again, after these guidelines were published, there are 4 more medications that are now FDA approved. It depends on the age. Some creams are indicated 3 months and above. Some creams are indicated 2 years and above. Some creams are indicated 6 years and above. It depends on the age. So go see your friendly neighborhood allergist or dermatologist. There's definitely creams we can offer you that are non-steroidal creams now. Yeah.
All right. Thank you to everyone who has attended our presentation today, and special thanks to Dr. Amma, Alexis, and Greg Clark Jr. for their presentations. I hope that everyone has found something helpful to take away from today's webinar. We have more Black People Like Me virtual conference presentations coming up this year. Please make sure to check our newsletters for more. You'll receive an email in a few days with the link to the recording, an evaluation, and additional eczema resources. Please be sure to complete the evaluation for today's presentation. Thank you again from all of us at Allergy and Asthma Network. Join us as we work every day to breathe better together.
Thank you.
Thank you, everyone.
Thank you.